Can I test? Yeah.
Yeah. Test. Test 1, 2. Check.
Yeah, I've seen that sometimes on margins, and I'm like, wait, I can even physically see the margin and it's sealed.
All right. So let's go ahead and get started. So the next few presentations are going to be a combination between Dr. Kauthar Ali and Dr. Raneem Al-Duraibi. They are both third-year graduate students in the PROS program, and they want to share some of their clinical experience with you. So again, after they're done with the presentation, or as one finishes, if you have questions, we'll take a minute or a few minutes to discuss each patient presentation, okay? So the one in the red is Dr. Kauthar Ali, and the other one sitting there is Dr. Raneem. Don't get the names mixed up. Go ahead.
Okay, good afternoon. My name is Kauthar Ali. Today I'll be presenting some patients that my very good friend and colleague, Dr. Al-Duraibi, and I have seen in the Advanced Prosthodontics Clinic at Loma Linda University. Those cases had a common thing between them, which is printed guides for surgery. So we're presenting guides that are bone supported, tissue supported, and tooth supported for implant placement and for bone recontouring. We're also presenting an innovative surgical guide that we came up with here at Loma Linda. So I hope you enjoy it. So for the first case, this patient is a This patient is a 73-year-old retired female. She presented to the Advanced Prosthodontic Clinic, and when she smiled, that's what I saw. Obviously, the patient has a low smile line. When she smiled, I noticed that she was missing multiple teeth, more obviously tooth number 7. And I also noticed that she has some staining and some plaque. When I asked her about her chief complaint, she stated that I want to replace my missing teeth in the lower arch with implants and the top with a denture. The patient lost the mandibular anterior teeth 30 years ago. She wore a removable partial denture after she lost her teeth, but then she lost the mandibular posterior teeth about 5 years ago. The patient also lost the maxillary posterior teeth 20 years ago, and number 7 was lost 2 months ago. And the cause of teeth loss, when I asked her why the teeth were extracted, she stated that it was primarily because of decay and periodontal disease. When I asked her about history, in terms of medical history, she stated that she was diagnosed with controlled diabetes type 2 in 2008, and in the same year, she was diagnosed with depression. Therefore, she's taking glipizide 10 milligram orally twice per day for the diabetes, and she's taking sertraline 100 milligram once per day for the depression. For allergies, she stated that she is allergic to tetracycline, and when I asked her about how controlled her diabetes was, she stated that it was controlled with the last HbA1c of 7. In terms of dental history, she stated that her last dental visit was 2 months ago for the extraction of tooth number 7. And she stated that she brushes and flosses irregularly, and she did mention that she has some dental anxiety. When I asked her about her social history, she stated that she does not use tobacco, she does not consume alcohol or any drugs. So this is the frontal view of the patient. From this view, you can see that the patient has lost the vertical dimension, obviously because she lost all the posterior support that she has, and she does not wear any removable partial denture at the moment. And this is the lateral view. From the lateral view, you can assess how the patient has a somewhat normal to a steep or acute nasolabial angle, since she still has her natural anterior teeth, maxillary anterior teeth. So as we were discussing the treatment options for the patient, she came with an initial plan, which is a maxillary complete denture versus a fixed complete denture for the mandible. And we, of course, went over all the treatment options that can be suitable for her case. And at the end, we decided to go with the treatment option that she came with, which is a conventional complete denture versus a fixed complete denture for the mandible. The patient was okay with extracting the maxillary anterior teeth, and we wanted to extract the teeth not only because first of all, they had mobility, deep pocketing, decay, and periodontal disease. But we also wanted to extract them because we wanted to have more control over the occlusion. And since we were planning a fixed prosthesis on the mandibular arch, we are limited by certain measurements for the restorative space. We usually need 14 to 16 millimeter of restorative space when we're planning a fixed complete denture for the mandible. So if we extract the maxillary anterior teeth, that would give us more control over the restorative space, because we can plan it according to both the maxilla and the mandible. But of course, the maxillary denture is also dictated by the smile, the aesthetics, and the phonetics. So all of that will be planned for when we move to the restorative phase. So for us to place the implants, for us to go over and move to the implant placement phase, we first had to proceed with extractions and pre-prosthetic surgery for the maxillary arch. The reason why we did the pre-prosthetic surgery, or we were planning to do the pre-prosthetic surgery for the maxillary arch, is the patient has marked buccal exostosis in the maxillary right posterior area. I hope it works here. Okay, the pointer is not working. But in this area here, you can see that the patient has buccal exostosis that creates undercuts. So if we make a conventional denture for this patient, it was going to rub against the undercuts and was going to create some sensitivity for her. And she's a very sensitive patient. So after I discussed that with the patient, she elected to go with the pre-prosthetic surgery at the time of extractions of the maxillary anterior teeth. And that's how we planned the flap for the pre-prosthetic surgery. I made a mid-crystal incision with 2 vertical incisions after I completed the extractions of the maxillary anterior teeth. And then with a Fisher burr, a carbide Fisher burr, I marked the area where I thought it was protruding more than necessary, or protruding, creating undercuts that would cause sensitivity or pain for the patient when she wears the denture. And then I used a ronger to chip that area, extra or excess bone off. After I used a ronger to chip it off, I used a bone file to smoothen it to ensure that there are no sharp areas that would bother her during the healing process. And then I sutured, I placed collar plugs in the extraction sockets, and I sutured over the extraction sockets and the surgical area for the pre-prosthetic surgery. And this is how it looked after 3 months of healing. As you can see in the last picture on the right, the undercuts that were present with the exostoses are no longer present now, and she healed within the normal limits. So we were very happy with the results. After the completion of the extractions for this patient, we placed immediate dentures for her because she wanted to have teeth. She didn't have teeth for a long time. And then this is how she looked after the extractions were completed. This is when she was smiling, and this is upon rest. And this is how the maxillary and the mandibular arches were looked like after the 3 months healing after the extraction. So after we've completed that phase and we placed the immediate denture, we decided to go ahead and do the planning for the implant placement for the mandibular arch. And as you can notice here in the mandibular arch, there are mandibular tori in both the right and the left area. But we did not choose to do any pre-prosthetic surgery for the mandibular arch until we placed the implants, because the final prosthesis for the mandibular arch is going to be a fixed implant-supported prosthesis. It's not going to have flanges. So we elected at the time of doing the immediate denture for the mandible, or I would call it an interim denture really, we elected to block the undercuts in the cast. So with the immediate denture, it was not going to rub against those mandibular tori. And then at the time of the implant surgery, after we planned the implant position more precisely, we would choose either to recontour those mandibular tori or leave them as they are if they're not really creating any issues for the patient. So now moving on to the bulk of the presentation, what we really wanted to discuss is how we would plan the implant placement from the time after you have your complete dentures in the patient's mouth and then until the implant placement. I think the most important thing before you do your scan with the dentures in the patient's mouth, if you have an edentulous patient to start with, you have to make very good dentures for you to plan the future implant positions. The denture itself has to be well-fitting. It has to have good adaptation, and it has to be stable in the patient's mouth. Luckily, with the immediate dentures that we placed, the maxillary and the mandibular dentures were satisfactory, so we chose to choose them for the scanning procedure and for the implant planning procedure too. So this picture, in the first picture on the left side, the blue denture, the purple denture that you see on top of the bone scan, that's the patient's existing denture, the immediate denture that we fabricated. We placed fiduciary markers on those on the dentures, and then we took the cone beam CT scan with the dentures and with the fiduciary markers. And then after we obtained the DICOM file from the cone beam CT scan, we planned the implant position based on the future teeth position and based on other parameters as well. So as you can see here on the lower left picture, I was planning to do 5 implants in the mandible because according to the literature, it's been supported by the literature that 5 implants supporting fixed complete denture is a good number. It has good success and survival rates. So that's why I chose to place 5 implants. And then the position of the implants, I chose to be on the first molar position, first premolar position, and then 1 implant in between the 2 central incisors. The position of the implants was not only dictated by the position of the teeth, but also by the buccolingual width of the bone. As you can see in the middle picture on the top, I made sure that my implant position, for each implant, there was adequate buccal and lingual bone surrounding all the implants. And I also made sure that I was respecting biologic boundaries. So I made sure that I am not invading the space that is required to protect the mental nerve. So as you can see, 3 implants were placed interforaminally, and then 2 implants were placed posterior to the mental foramina. Also, as I said, when you're planning for a fixed CD, you have to have the restorative space in mind. So since I was planning to do a fixed complete denture with a titanium framework that is covered by acrylic, I usually need about 14 to 16 millimeter of restorative space for that one from the implant platform. So I did my measurements to make sure that from the implant platform to the occlusal plane, so from the implant platform up to the teeth of the opposing arch, I have at least 14 to 16 millimeters. And if you can see, some of the implants here were below the level of the bone because the bone needed to be reduced for me to get that restorative space. And that's something that I'm gonna discuss later when I talk about the bone reduction process that I've done for this patient. So after I finalized the implant planning based on all the criteria that I need to look for, I started planning for the guide for the bone reduction and for the implant placement. In this situation, I chose to go with a bone-supported guide. Usually, if you have an edentulous patient and you fabricated a complete denture for that patient, you have several options. You can go with a tissue-supported guide or a bone-supported guide. With the tissue-supported guide, according to my own clinical experience, I found that the tissues have some resiliency, so I'm always not very happy with how I'm fitting the denture in, and I don't know if it's really as accurate as I want it to be during the surgery itself, even though it's stabilized by anchor pins, but I like to have my guide stable and not move during the surgery and not be compressible. So I wanted to do a bone-supported guide for this patient. With the bone-supported guide, there is also a chance of inaccuracy that can occur because when you take the cone beam CT scan, there is some scatter or artifact that happens. It's not 100% accurate. But I did a step in the implant planning software to ensure that the bone model that I'll be creating my guide on is going to be as accurate as possible. That step is called bone segmentation. So if you see the 2 pictures on the right side, the top picture is the bone model as we obtained it from the cone beam CT. And the bottom picture is the bone segmented model, which is in green, superimposed on the original bone model. What you do basically when you do the bone segmentation step in the implant planning software, in my situation, I used Blue Sky Bio. There are so many implant planning software, but I'm just more familiar with that program. You go into the sagittal and the coronal and the axial section of the bone model section by section. And then you remove any artifacts. You outline the area that you think you're very sure that this is actually bone and not scatter or not an artifact. And then after you do that step, which takes a little bit of time, you get a more accurate model, which is in green. And that's the bone model in green is what I used to fabricate the guide on. So for me, since I mentioned in the previous slide that I was going to do a bone reduction to get the restorative space for my final prosthesis, which is a fixed complete denture, I would have to start my surgery with a bone reduction guide. So I used the segmented bone model, and I created this bone reduction guide that would wrap around the area that needed the bone reduction, which was the area in the middle here. See how there are like protruding bone segments that are going above the level of the bone reduction guide. This is the area that needed to be reduced for me to get a good restorative space. And when I planned the bone reduction guide, I planned it to fit very well on the buccal, mesial, and distal of the area that I wanted to be reduced. But I made sure that it's not pressing on the mental nerve, because I didn't want to cause any transient paresthesia on the patient's mental nerve. And I planned anchor pins for the bone reduction guide because I wanted that stability while reducing the bone. If you don't stabilize their guide during the surgery with anchor pins, there is a chance that it would wiggle, and you don't want that to happen during the surgery, because then your bone reduction is not going to be as accurate as you want it to be. Usually 3 anchor pins are enough, but I usually place more than 3 because it depends. Sometimes during the surgery, you don't have the access that you thought you would have because of how strong the patient's lip and how well you can retract the lips, how well the patient can open. So I usually put more than necessary just in case I have any issues with the access during the surgery. And this is how the bone reduction guide looked during the surgery. It looked very similar to what we planned. And then this is how we planned the bone reduction in the software. So we wanted the bone to be flush with the bone reduction guide after we're done. And this is how it looked after the surgery. It looked very similar to what we planned. The bone was flush with the level of the bone reduction guide. Moving to the next step, which is the floating implant placement guide. So with help from my colleague, Dr. Abdelaziz Zaid, he's a fellow at the Digital Fellowship at the Prosthodontics Department at Loma Linda University. We wanted to create a guide that is kind of different than what we are used to doing when we do bone reduction and implant placement. We usually, if you go into the literature or if you ask somebody who is experienced in placing implants in the mandible, a lot of clinicians would use a stackable guide that would fit on top of the implant placement, on top of the bone reduction guide. That guide works very well. It has so many advantages, but it doesn't give you a lot of access and visibility during the surgery, and it doesn't give a lot of channels for irrigation, which is something very common if you're doing guided surgery. You know, if you're doing a fully guided approach to surgery, there is a chance that you're not going to have as much as irrigation as if you're doing a freehand. So we wanted to do a guide where it would provide us with the fully guided approach, but still have more access and visibility and irrigation. So what we did is, after we planned the bone reduction in Blue Sky Bio, we exported the bone reduction guide with the reduced bone model to Meshmixer, which is another software. And then we also imported the implant guide tubes. Those tubes, you can make them appear in Blue Sky Bio on top of the implants where you plan your implant position. And then, because they would indicate basically the future implant position. And then after you plan them in Blue Sky Bio, we also exported them to Meshmixer. And after we've done that, we connected the bone reduction guide with the implant guide tubes, and we supported the guide tubes together. That way, the guide tubes will dictate the implant position. It will give us the guided surgery feeling that we want, but still we'll have channels to see the bone. These areas, these windows, will be the areas that we will be able to visualize the bone and have irrigation. And this is how it looked in the surgery. So as you can see, you can visualize the bone, and if you place your implants, you'll have the irrigation flow in the area that you're planning to place the implant. That would create less heat, so it would help with the success. Hopefully, it would help with the future success of the implant itself. Now, as I said, these are the advantages of the floating implant placement guide that we are proposing. However, the limitations of this guide would be that you will have to remove the initial bone reduction guide and then replace it with the floating implant placement guide, as opposed to the stackable implant placement guide, which I will be showing you in this picture. With the stackable guide, you would plan your implant placement guide to fit on top of the bone reduction guide. So you wouldn't have to remove the first guide and then place another guide in its position. You would just have to take it and basically click it on top of the other guide. However, I found that sometimes if the bone reduction is not completed as well as you want it to be, or you left a little area, even if that area is not really significant for the implant placement, the second guide would not fit very well on top of the first guide, and that would give some deviation in the future implant position. So we elected to go with the floating implant placement guide for my patient. And this is how the implants looked at the uncovery stage. This is how it looked at the end. And then this is the panoramic radiograph after the implants were placed. And this is how it looked after healing. With my very limited clinical experience, I was very happy with the results that I had, and I was willing to try that guide many times after this case.
Can we just take a moment if they have any questions on the first patient situation?
Sure.
Any questions? So I have a question. So when you have a guide like you made, one of the things you have to do is reflect a big flap, right?
Yes.
And there's no way of getting around it.
I don't think there's a way of getting around it, honestly.
When you have to remove bone, obviously you have to raise a flap. And when you raise a flap and you replace a reduction guide like she did, you have to think large flap so you can see it. To me, that is the only thing that I would think is a major disadvantage, because you have to fit the guide within the, it's such a big guide that you fit it in, so to reflect a large flap. Otherwise, it's a very nice technique too, with a lot of advantages, because it gives you a little bit more precision. Right? And any other questions? Well, yes.
Doctor, can you go over the bone segmentation?
Sure. So if you go into the implant planning software, before you plan before you draw your bone reduction guide or your surgical guide on top of the bone itself, for you to make sure that your segmented model, or the model that you'll be drawing your guide on, is very accurate and your guide will fit in the patient's mouth exactly as you planned it, you have to make sure that you remove any artifacts, any scatter that can happen during the cone beam CT scan. So basically, if you go into the implant planning software, there's a panel called the segmentation. You go into that panel, you click it, and then automatically it moves you into another plane, like a plane that would give you a sagittal view, an axial view, and then a coronal view of the mandibular bone or the maxilla if you're planning to do the maxilla, but we usually do it for the mandibular arch. And then you have to go, when you're in those views, you have to move through the bone from the mesial to the distal, or from the superior border to the inferior border, or from the anterior to the posterior, because you're looking at 3 different views. So you have to move all of these three movements, and you make sure in all the sections or all the planes, you're only outlining what you think is bone. You're not outlining scatter or not outlining soft tissue. That makes sure that whatever bone model that results at the end of the segmentation step is a more accurate representation of the patient's situation in comparison to taking the cone beam CT scan bone model as it is without doing any modification to it. Any more questions?
So Dr. one more question. When you remove the bone reduction guide and you're replacing it with the building guide, are you securing it with the pins in the same position?
Yes. So your anchor pins are going to guide you on where to place that second guide. That's why it's still very accurate. Even though you removed some of the bone that was used maybe for securing the first guide, your anchor pins are going to guide you into placing that second floating implant placement guide. I think there's a question.
Okay, yeah.
So I have a question. So your first guide looked like it went over the jaw, and that's when you cut off excess bone. And then another one over top of it, you never pulled that one off. And then that was used to drilling your holes.
So for the guide that I used, no, we had to remove the bone reduction guide first and then replace it with another guide. But what you're describing is another type of guide that can be used that can pop over the bone reduction guide. I had pictures of it, but we did not use it during the surgery.
Obviously, you didn't know.
How do you make this technical cost compared to the first one? This version guide on the same guide.
I'm sorry, your voice.
How do you connect it? How do you fix it?
Oh.
So just repeat the question, Dr. Ali, so the rest of them can hear.
I think your question is how can you make sure that your second stackable guide fits over the bone reduction guide, right?
Correct.
So first of all, it depends on how well the bone reduction is completed, because that flat surface that is going to be resulting after you do the bone reduction guide is going to be stabilizing the stackable guide. But then you have to have other reference points to make sure that you're fitting your stackable guide correctly. And for me, when I planned the stackable guide for this patient, I used the anchor pins guide tubes as my other references. So I made sure that when I seated the stackable guide, it was fitting over those guide tubes. The guide tubes have a semilunar shape from the top because they're cylindrical. So I made sure that when I drew my stackable guide, it was basically outlining the semilunar shape of the top of the tubes, of all of the tubes. So if I was placing, I think I planned six anchor pin guide tubes, and I used all of them to stabilize the second stackable guide.
Maybe you can go through those slides just quickly, just to recap.
Sure.
It probably is more visual.
So if you see those are the anchor pins guide tubes, and the second guide fits over them. So it's stabilized by more than one, not just the bone, the reduced bone, but also those reference points.
Doctor, you mentioned a different software that you use for your floating.
Mm-hmm.
What's the name of it again?
Mesh mixer.
Mesh Mixer.
Okay, so that's a good question because I was going to bring that up. Devin kind of alluded to that. There are companies that will actually do this for you, create the guides with the reduction guide, and then you can stack it on, and sequence is one. But the price tab that comes with it is pretty high. This is, I don't know what the price cost was this for you to get it done in-house, but it just basically used Blue Sky, right?
I think for Blue Sky, it's free to download, and then They give you free exports at the beginning, and then after you deplete your free exports, you pay $25 per export, which is not very pricey. And Mesh Mixer, you can use it for free. So
Right. So then that leaves you with a printer. We use something called what is it? Did you use the Formlabs or the other one? It's SprintRay.
for this patient, I used the Forms Lab.
Forms Lab. So that's an investment that will pay in its own way. The Formlabs is about, if I remember right, about $5,000. And there's better ones that is more sophisticated, but from a precision level, it gets the job done. And so you're not paying a lot of money to get something that is almost equally accurate or precise. Nothing is really accurate as a commercially made one. And the beauty of it is when in a graduate program, you can make mistakes and you can reprint and you can play around with the software to modify your idea. So there's advantages to it.
And doctor, can I add one point
Sure.
to that? Even if you're not planning your guide, even if you're not doing it yourself, you're referring to an outside laboratory to do your surgical guide, I think it's very important that you know how to do it and what mistakes you should avoid, because if you refer to an outside laboratory, you have to check the work that you've done for you. And then you don't want to have the mistakes during the surgery. You want to recognize those mistakes before the surgery, so you don't have any issues during the surgery, because if you have issues, it's going to lengthen the surgery time, the patient's going to be unhappy, the anesthesia is going to wear off. So it's better to recognize these things and know them beforehand if you're using the guided approach for surgery.
All right. Go ahead. One more question. Yes, David.
Yeah, did you remove the lower tori the same way as you did on the maxillary?
Okay, good question. I thought you guys are going to ask me that question. So if you see the picture at the end, you'll notice that I did recontour the tori a little bit. I made them a little flatter, but I did not remove them 100%. It's because, again, the final prosthesis would not have any flanges. But when I did the bone reduction, when I flattened the bone, I went on the lingual area of the mandible and I used a bone file to smoothen the area, because I didn't want any sharp edge, because any sharp edge would create issues for the patient when she's healing. And when I did that step, I chose to recontour the bone just slightly, and that's all I've done.
Contouring the bone with a diamond file or something?
I used a bone file.
The bone file?
Yeah. For this patient, I used a dual scan. You're right, but if you're planning a bone reduction guide, it's not really necessary to do the dual scan, because the dual scan is usually done because you want to also scan the intaglio surface of the denture. That's why I didn't go over the dual scan process very thoroughly, because it was not crucial for this patient. But if you're doing a tissue-supported guide where the intaglio surface is going to help, the intaglio surface is crucial and you want that intaglio surface to fit very well, and then you place your anchor pins, the dual scan is crucial. You have to have a separate scan of the denture and then a scan of the denture in the patient's mouth. But in my case, I was doing a bone-supported guide, so it's not that crucial to have a dual scan. No, but it's a good question.
All right, Raneem, you've been waiting patiently. You're next. And then I think, Kauta, you're back after. All right. Thank you.
So, good afternoon, everyone. My name is Raneem, and the second case I want to share with you is a tissue-supported surgical guide. So, the patient is an 80-year-old female. She's retired, and the close-up smile shows that she is considered a low smile line, according to Jan and others. And they classified the smile line into 3 basic categories in the 1980s. So they categorized the high smile line as when the 100% of the clinical crown, along with the continuous band of gingiva, appears during smile. The average is when 75 to 100% of the teeth show during smile, and the low smile line is when less than 75% of the teeth are visible during smile. And we can also see the mandibular teeth when she smiles. And this is considered normal for her age because according to the literature, the muscles of the lips become less elastic and less mobile. So as a result, we can visualize the mandibular teeth more when the patient smiles. And when I asked her about her chief complaint, she stated that my denture is falling off and sometimes hurt. I want to explore the option of implants. So when I asked her further about her chief complaint, she mentioned that her teeth got extracted back in 2016-17, and she got maxillary complete denture made in 2017. And she mentioned that the cause of the teeth loss were periodontal disease and caries. For the medical history, she mentioned that she got her kidney stones removed in 2014, and she also broke her foot in 2017. But she didn't undergo any kind of surgery. They just put her in a boot for a couple of months, and they also diagnosed her with gastroesophageal reflux disease, osteoporosis, hyperthyroidism, and chronic obstructive pulmonary disease. And I'm going to talk about the medication that she takes in more detail in a minute. And she also mentioned that she has allergies to sulfa drugs. For the dental history, she mentioned that her last dental visit was in 2017 when she came for the extractions as well as the placement of the complete denture. And she also mentioned that she brushes twice per day and she flosses irregularly. She also said that she doesn't smoke or consume alcohol, and she doesn't consume any drugs. So the first medication that she takes is the lansoprazole. It is used to treat the symptoms of GERD, and a less common side effect of this medication is xerostomia. So this medication is considered a proton pump inhibitor, and it works by reducing the enzymes by blocking the enzyme production from the stomach walls. So I wanted to look in the literature to see if there's any association with this type of drug and implant failure. And I found this systemic review and meta-analysis, and they found that there was an association with proton pump inhibitors and implant failures. They clarified this by stating that this type of medication interferes with the osseointegration of the implant by reducing impairing the uptake of calcium from the intestine. And we know the calcium is important for the bone density. The second paper that I found is a consensus report, and they mentioned as a consensus statement that the intake of PPI is associated with a statistically significant increase in implant failure. And they based this statement on 2 cohort studies that included 1,798 patients. The second medication is vitamin D, and she takes 50,000 international units per day. And the reason why they prescribed this medication for her is because she takes Prolia. The third is the methimazole, and she takes 5 milligrams every other day to treat the hyperthyroidism. And again, I wanted to see if there's any association in the literature with implant failure. And I found this paper that included many systemic diseases, including the hyperthyroidism, and they found that there was no reason to believe that these systemic diseases could cause an increase in incidence of the early failure of the implant. The fourth medication is Prolia, and she takes it as an injection every 6 months, and the reason for that is to treat her osteoporosis. And Prolia is considered an anti-neoplastic monoclonal antibody, and it is reported that it could cause the medication-related osteonecrosis of the jaw. So again, I wanted to see if this is true and if there's any studies that supported that. So I found this systemic review and meta-analysis, which I found interesting, because they stated that they couldn't find any relative information on the anti-resorptive drugs and implant therapy. And they included, or they gave an example of the denosumab, which is another name for Prolia. But they said that they believe that there is an association with certain types of patients that take a certain type of medication with MRANJ. So they mentioned that patients who take high doses of the anti-resorptive drugs, which is usually the case with patients with cancer and bone metastasis, and also patients on oral bisphosphonate for a long period of time, and patients with comorbidities. The last medication that she takes is the Trelegy Ellipta, which is used to treat the symptoms of the COPD and prevent the bronchospasms. And there was no relation with implant failure with any patients who have any respiratory diseases. So moving to the frontal view of the patient, this is the patient MIP rest and smile. As we can see, her facial thirds are proportionate, and we can assess the maxillary denture in this view. And during the examination, I thought that the maxillary denture was adequate in terms of the amount of teeth showing during smiling and the occlusal vertical dimension. And this is the lateral view of the patient. Again, we can assess better the occlusal vertical dimension from this view. And we can see that she has a straight profile, but her upper lip, according to the E-line, is not considered within the normal limits because the normal for a Caucasian female is 4 millimeter plus or minus 2, which is like from the maxillary lip to the E-line, which in her case is a little bit more. And she also has an obtuse nasolabial angle. So when fabricating the new overdenture, I would try to protrude the maxillary teeth a little bit more to give more lip support. But this would not really affect the planning stage of the implant positions. And her lower lip, according to the E-line, is within normal limits, and also her mentolabial angle. So this is a preoperative OPG of the patient. Generally, she has normal anatomical structures except for the pneumatized sinuses and the limited bone in the maxilla. But I explained to her that I would have a better view and assessment of the bone after a CT scan, and the possibility of bone grafting with or without sinus lifting would be determined after a CT scan. So when she went and did the CT scan, as Dr. Ali mentioned briefly about the dual scan, because I wanted to do a tissue-supported guide, so I planned for a dual scan. So what they did is they scanned the denture first, and then they scanned the patient wearing the denture. And what I did is I superimposed the denture into a CT scan, and then you can see it's the red outline here. And then this space here is the tissue. And then what I did is I first planned the implant position where I want them, and I assessed the amount of bone that I have. And these implants are 8 millimeter in length. So I thought that I had sufficient bone and no grafting would be needed. And the implant positions that I planned for are site number 5, 7, 10, and 12. And the implants were bone level tapered implant by Straumann, and they were 3.3 by 8, and they are SL active. So when I was happy with the position of the implants, I wanted to fabricate the tissue-supported surgical guide. So what I did, because I wanted to be tissue-supported, I superimposed, or I planned it according to the denture, so the outline of the denture. And then I designed it, sorry. So I designed it in a way to place the anchorage sleeves just to have stability during the surgery. And the reason why I placed 6 anchorage sleeves is because I wanted to anticipate the possibility of converting the flapless approach to a conventional flap. So if that situation occurs, what I will do is I would remove this facial part of the surgical guide along with these 3 anchored sleeves, and I would stabilize the denture with the anchorage pins on the palate. So before I go to the surgery part itself, I wanted to talk a little bit about the flapless approach. So some of the advantages of the flapless approach is that it reduces the surgical time. It gives better patient morbidity. and it also preserves the tissue contour as well as the vital supply. But some of the disadvantages are the inability to really visualize the bone during the implant placement, the possibility of thermal damage due to the inadequacy of the irrigation reaching the bone, and if the bone recontouring is needed during the surgery, it would be difficult to do during the, or you wouldn't be able to do it during the flapless approach. And the most common complication occurring during the flapless approach is that you would have or possibility of having a perforation or fenestration during the implant placement. But when looking at the implant survival for both techniques, both showed high implant survival rates. So before I started the osteotomy, I tried the surgical guide in the patient mouth, and then I stabilized it with the anchorage pins, and I did the entire osteotomy through the guide. And during the osteotomy, I felt that the bone was soft. So in that instance, I decided to open a flap before I placed the implants, just to have a better visualization of the bone. And if I had any fenestration or dehiscence, I would be able to place bone there. So this is the incision that I did and the implants after I placed them. And this is after the suturing. And these are the PAs immediately after the implants were placed. Does anyone have any question before I move on to the third case? Yes. Yes, because originally I wanted to do it.
Can you repeat the question? Because people on Zoom, they won't hear the question.
Okay. So he asked if I did the osteotomy through the surgical guide and then I opened the flap, right? No, before. Yes, because I wanted to do it flapless, but when I did the osteotomy, I felt the bone was very soft. So, and I knew that this is one of the complications of the flapless is when, if you don't have that much or you don't have optimal bone, you might have dehiscence or frustration. So I didn't want to take the risk of having that and not knowing and doing like, or risking the complications. No, I just put a cover screw and then I buried I did the suturing just to wait for the healing and then I'll do the uncovering.
So this is a maxillary overdenture?
Yes, it's planned
so
for maxillary.
Just to ask you guys, what do you think would be the occlusal scheme for this patient if it's a maxillary overdenture? Based on what you know so far. Okay, now there's a little bit of a curved ball here, right? Balanced occlusion is the right answer, but you're opposing natural teeth, and natural teeth don't come under your control unless you crown all of them, which is ridiculous. I understand that. But sometimes if the occlusal plane is really not in your favor and everything is like a roller coaster and the patient has some significant issues, that is when you need to think about how do I gain control, and the patient is indicated for restorations on the mandibular arch